Philip, what we've touched on this a little bit, and I think you did in one of the introductory comments that you made, but if we look at the comorbidities that are associated with non-radiographic axial SpA, I think my first question to you is, what are these? And my second question to you, that bears on Atul's point about spectrum, is are they different than what we see in radiographic axial SpA?
So Sergio, this is a very important point or issue to talk about comorbidities as well as associated conditions. And it really makes it imperative that we step outside of as rheumatologists, our narrow shoes as rheumatologists into a broader place of being clinicians, physicians for patients, because some of these comorbidities are very important, need to be attended to, need to be recognized. And many times the patient may not have a primary care situation where they're really getting these things addressed. So we have to sort of bird dog whether or not they're being taken care of. So let's start with this, what I call associated conditions. So the big three are uveitis, psoriasis, and inflammatory bowel disease. And I call them associated conditions because all of them have pathologic mechanisms that are shared with the basic pathologic mechanisms of axial SpA. And so we see a higher prevalence of all of these in both radiographic axial SpA as well as non-radiographic axial SpA. I should acknowledge that many of the more definitive investigations of comorbidities and associated conditions have been done in an ankylosing spondylitis population historically, so patients with radiographic disease. We have much fewer in the way of definitive studies in non-radiographic population, but the few that have been done have suggested that there is a similar degree of comorbidity in the non-radiographic population. I can remember one study from Europe that showed a little bit less in the way of uveitis in a non-radiographic population than radiographic. But I think the take-home message for the listeners here should be, let's just assume that that these issues can be present and we need to attend to looking for them. So besides uveitis, and by the way, uveitis, that's one of your special areas, Sergio, but that can be sometimes a gateway into the diagnosis. If an astute ophthalmologist who is seeing a patient with uveitis in front of them, maybe they get an HLA-B27 as part of their laboratory workup, but asking a few questions of the patient. Do you have any problems with back pain? And getting them referred to a rheumatologist is important. Same with IBD. If the patient has evidence of Crohn's or ulcerative colitis, having the gastroenterologist to ask a few questions of the patient to get them to go see a rheumatologist. There was even a recent study done at NYU in your city, Sergio, where they look back on the MRI scanning that's done of Crohn's disease patients, so-called MRI enterography, and found that there was evidence of sacroiliac inflammation in many of the patients that had just been missed by the radiologist when they were interpreting the MRI scan. So there are various avenues that can improve getting patients with these associated conditions to rheumatologists for better management of their musculoskeletal disease.